This is a surgical video demonstrating the stepwise approach to laparoscopic-assisted mini-laparotomy myomectomy with a focus on improving hemostasis. The authors have no conflict of interest to disclose. The objective of this video is to illustrate a surgical technique to decreasing blood loss using a cervical tourniquet at the time of laparoscopic myomectomy. Uterine leiomyomas or fibroids are benign smooth muscle neoplasms that typically originate from the myometrium, stemming from a single progenitor myocyte. They are estrogen and progesterone sensitive tumors. 20 to 50% of patients with fibroids are symptomatic, causing abnormal uterine bleeding, iron deficiency anemia, dysmenorrhea and cramps, bulk symptoms, and/or reproductive issues. The impact depends on their size, location, and number. Patients who have failed medical treatment or fibroids affecting fertility will require surgical management in the form of myomectomy. Surgeries involving the uterus and fibroids can result in significant blood loss due to the abundant blood supply to these tissues. There is a 20% blood transfusion risk for myomectomy cases. A systematic review published in 2014 reviewed and compared different techniques to minimize intraoperative bleeding, either pharmacological or mechanical, preoperatively or intraoperatively. Our technique relies on preoperative GnRH agonists, intramyometrial vasopressin, and cervical tourniquet. Our case presentation is a 35-year-old G0 female presenting with abnormal uterine bleeding, anemia, urinary symptoms, and infertility. An MRI shows a large type 2 to 5 7 by 8 by 7 cm fibroid with distortion of the endometrial cavity. Here we'll demonstrate a surgical technique for myomectomy that relies on first securing hemostasis laparoscopically. We begin by performing a laparoscopic survey, creating windows into the broad ligament, followed by placement of a cervical tourniquet using JP drain tubing to temporarily occlude the uterine arteries. This is followed by myomectomy and morcellation of fibroid and closure through a mini-laparotomy. Equipment needed for this technique is a Jackson-Pratt drain tubing and a plastic ring retractor. We will now proceed to our surgical video. We begin by performing a laparoscopic survey to correlate intraoperative findings of the fibroid size and location to prior imaging, ensuring the lower segment is amenable to application of cervical tourniquet. Here we can see we have adequate access both anteriorly and posteriorly. Starting with the right anterior broad ligament, an incision is made, and the bladder flap was developed to the contralateral side. With traction and countertraction, careful dissection into the avascular plane was performed to minimize bleeding and staining of the retroperitoneal space. The right paravesical space was further developed. The uterine vessels were identified and shown in red. Using a grasper, the posterior leaflet of the broad ligament is tented up to identify an avascular space lateral to the uterine vessels. An incision was made and a window was created with opposing traction parallel to the vessels to minimize bleeding. The right pelvic side wall was inspected and the ureter can be seen formiculating transperitoneally, highlighted in yellow. The same steps were repeated to create a window in the left broad ligament. We inspected the left pelvic sidewall and we were not able to identify the ureter transperitoneally. The retroperitoneal space was explored and the ureter was identified and highlighted in yellow, and the uterine artery highlighted in red. A 4 cm mini-laparotomy is created. A small incision was made in the peritoneum laparoscopically to increase the ease of abdominal entry. A ring retractor is used to maximize visualization of the fibroid during extraction of the specimen. It is also used to provide pneumo-occlusion once the mini-laparotomy is made. A Jackson-Pratt drain tubing is introduced into the abdomen through the mini-laparotomy. We prefer to use a Jackson-Pratt drain tubing for the cervical tourniquet rather than other options such as suture or Foley tubing for multiple reasons. The flat end of the Jackson-Pratt tubing provides just enough rigidity for easy manipulation of the tube through our broad ligament windows as demonstrated here. A uterine manipulator is instrumental in deviating the uterus to provide visualization through our broad ligament windows, so the other end of the tubing can be seen. The ends of the Jackson-Pratt tubing is then brought through the mini-laparotomy for the knot to be placed. The material of the tubing itself behaves like suture when tying the tourniquet down, where it can hold the knot well without slipping and provide enough tension to apply pressure on the uterine vessels while minimizing trauma to the tissue. Penrose drain material stretches like elastic band without slipping down adequately for a strong knot. Lastly, this type of tubing is also silicone-free. A spinal needle is introduced into the abdomen and diluted vasopressin is injected along the planned incision site. The diluted vasopressin vasoconstricts the superficial uterine vessels, feeding the fibroid and hydrodissects to create a plane for enucleation of the specimen. An incision is made on the uterus to expose the fibroid. The fibroid was then partially enucleated. Minimal blood loss can be seen and the uterine tissue remains blanched from the combination of vasopressin and occlusion of the uterine vessels from the tourniquet. The uterus was then brought to the anterior abdominal wall for a complete enucleation and extraction of the fibroid through the mini-laparotomy. Once again, the uterus remains hemostatic through the morcellation process. The tourniquet works well even when there are multiple large and even massive fibroids, but not when there is a significant cervical or lower segment component that prevents either broad ligament windows or proper placement of the tourniquet. In this case, vascular Bodoc clamps on the uterine artery or internal iliacs are employed. A multi-layer closure of the myometrium is performed. We find it more efficient to suture through the mini-laparotomy, but in cases of a lower segment posterior fibroid, laparoscopic suturing is required. The tourniquet is then removed and hemostasis is ensured. Finally, a layer of anti-adhesive barrier was applied. The estimated blood loss was less than 100 cc's. Here is a flowchart summary of the technique described, with an emphasis on step 2 and 3 describing steps to improve hemostasis. Thank you so much for watching this video, and we would like to thank our collaborators.